The knowledge, the computing and the processing and the communication, all of those things now sit in my hand. And when you think about that, in my lifetime, I am not that old. We've made huge leaps and bounds in such a short period of time, like genuinely in my lifetime, but like part of my lifetime. It's pretty impressive to think how far we've come. And it just makes me think about how far can we go in terms of the delivery of health services by thinking about that journey. And I don't think that we're as quick in health to do that sort of change and adoption. It does lag in terms of our lifestyle uptake of information and technology. So I wanted to talk today about some of the things that we're doing. I always think about the patient journey, probably comes from my clinical redesign background. So I want to tell you a couple of stories about things that we're doing, a couple of things about, I might lecture or spruik on a couple of things that really annoy me. And then, as I said, talk about how we're going to try and manage all of this going forward. Now, my health record is really interesting. I personally love my health record. I think it's a great way for all of us to keep our information. Interestingly, with my little leg issue, you know, someone said the other day, oh, have you got any old x-rays or scans? And I'm like, well, no, because I moved house about 12 months ago and I threw them all out. But the opportunity for us to carry our electronic health record anywhere we go, I think is really underutilised. But it is interesting, the uptake of use. When I had a little look, the number of people that are using it. And the other bit that I found really interesting is that public hospitals are the biggest user of the electronic health record in terms of pulling information out. So there is hope, I suppose. But my gripe, and the reason that we're talking about this, is I went to see the GP to have a blood test, this was some time ago, and the form was pre-printed with, do not release this to the electronic medical record. Now, I get their logic, you know, what if it says something you don't want to see, etc., etc. But in the end, the question for me is whose data, whose information is it? And it's actually me as the consumer. And interestingly, that healthcare providers need to have the discussion with the patient about how that data, that information is to be managed. There was no conversation. I walked out with a form that said, do not enter this, without a conversation. So that's just my bent about my health record. And for me, that's really the beginning of the healthcare journey. That's that, how do you coordinate all of the bits that happen beforehand? But if you think about coming into public health, and that's my background mostly, is public health systems and services, one of the things we've just started to explore is a digital front door. I didn't really understand what digital front door was until I got more involved. But it is about the opportunity to try and access healthcare at the right level at the right time. And again, I would say, I landed from Malta in Australia about 4 weeks ago with my lacerated leg and my DVT. What do you do on a Monday when you have a lacerated leg and a DVT? Can't get into your GP for 2 weeks. There was no way I was going to the ED. Lucky I had a friend of a friend and I could access healthcare. And the idea behind a digital front door is to go into a system that can help you navigate and find you the right level of care in the time that you need it. A lot of them use chatbots. I hate chatbots. They pop up. But you know what? They actually work sometimes. And so thinking about this cascading, you know, chatbot doesn't work, and national direct line, you know, cascading your way through to get people to the care at the right time. Don't need to go to ED at midnight. Maybe you could wait till 10 o'clock in the morning and access a different service. They're quite prominent in Canada. And there's some districts in New Zealand that are looking at using digital front door to better coordinate access to healthcare in a timely way. And we think for Central Adelaide there's a whole lot of opportunity because we get this sort of volume of work in the centre to try and navigate. And there are lots of simple mechanisms in digital front door, even simply locking people out by postcode. So if somebody contacted the digital front door for Central Adelaide from New South Wales, for example, you know, they might get locked out. I'm not saying that they would, but they're sophisticated in terms of how they manage. So we are just at the moment talking through what are the opportunities for us to implement digital front door to try and help us manage some of this emergency demand that we're living with. We were talking about prehab before. One of the other projects that's sitting sort of alongside of that is Personify Care. It's probably the wrong name because that's actually the name of the company. But Personify Care do a lot of digital access. They have a digital access platform, and we've been doing some trials in terms of using Personify Care, mostly around surgical access. So it's the way people can do all of those, you probably don't even remember, but multiple forms, your admission form, your day before your admission form, your anaesthetic form, your consent form, does everybody know where you are form. So the Personify have set all of that up so that a whole lot of your pre-admission, usually in a planned pathway, can be entered on this particular platform, linked to our EMR, mobility, so people can do it anywhere, and starts to be able to sift and sort people, so you can work out whether what sort of level of workup that they need. So the Personify Care pathway for us really is our first, and it's real in terms of our first foray into sort of a digital front door in a small but narrow way. Lots of, I can't quite see it up there, might be on the next slide. Lots of the clinical specialties have uptaken it. You can see in that wheel there all of the different specialties that are starting to apply a pre-admission pathway using Personify Care. And we are absolutely, one of the resistance around using this would be certainly about patient experience and all of our older patients not wanting to use it. And yet the feedback we have today is that there are very few people that actually can't broker a mechanism to use an electronic tool to access the hospital. They probably rely on daughters. I did have to do this for my dad at another site, but people will buy in and broker ways to do this rather than having to go through the old ways of sort of managing. And Personify Care, as I said, is sitting underneath and starting to enable the application of evidence-based care, and things like My Prehab is one of those that is using some of the Personify Care platform underneath it. 20 plus specialties, I knew there was a number I was looking at, 20 plus specialties within Central Adelaide have already taken up the uptake of Personify Care. You know, 270,000 plus patients have engaged with the model, and lots of patient satisfaction with a different way of entering a system to access your care. Really keen to look at the sort of digital signatories. How could we now do digital consent rather than a piece of paper? How do we, you know, start to expand? But also then how do we close the loop? How do we get feedback from patients about the care that they received? The other one I wanted to talk about, and talking about My Prehab, and Professor Jane Andrews has certainly championed that, is she has been championing AHMS. AHMS is a deterioration index that we have been piloting here in Central Adelaide, particularly again in surgery, and that is very much focused on trying to identify, by surveilling big data, trying to survey the data to see where there are signs of clinical deterioration. And so it surveys definitely vital signs, not surprisingly. But what are the opportunities to troll the EMR and the data to send alerts, particularly to nursing staff in the first phase? It has been piloted in a private hospital, and it definitely shows that they've had reductions in MER and unplanned ICU admissions. So there is a bit of a link between the ability to survey and predict clinical deterioration a little bit earlier, And so we've been trialling it as a shadow on, I think it's 4 surgical wards, with a view to then deploying into real time and try to roll it out across the organisation. There's a dashboard, and the advantage of the dashboard is, particularly when you think about healthcare out of hours, it means people can be sort of keeping an eye on the whole of the clinical population at one time by able to have a look at the flags and alerts centrally, as well as it being managed closer to home or closer to the ward. And the pilot that we've done was almost 10,000 patients over 100 days. And one of the challenges around these is do staff start to get an alert fatigue? You know, does this keep beeping? You would already know. We know that people will ignore alarms, just turn them off, mute them. But it's only about 1.4 alerts a day on a ward. So I think the fact that there isn't a large volume of alerting, ICU admissions were definitely predicted by the deterioration index before they were actually clinically decision to send them to ICU, and was starting to detect the adverse events or deterioration in patients. So a big piece of work happening in surgery, and certainly with ICT and data capability and all of those data matching and integration. But watch this space. I think we will see that moving through. We're also talking with University Health Network in Canada. They use a model called Halo. So rather than having a carer or a guard on a patient, they do video monitoring and have a central station. And one of my colleagues was telling me the other day, the video it's a bit like, I don't know whether you have video security systems at home, because you can, on your app, if someone's breaking in, you can talk to them and say, get out of your house. You can also talk to your son when he's somewhere he shouldn't be, but anyway, that's a whole nother story. But they can talk. So if a patient's restless or getting out, they could say to them, you know, can you just hop back into bed? I'll get someone to come. So, but you can save quite a large cost, because you don't have to have as many people physically, and again, centralised sort of monitoring to keep patients safe. So lots of opportunity, I think, in this clinical deterioration space for healthcare organisations. And then the last one for me is a little bit about getting out of hospital. How do you, what in terms of the patient journey? And so I'm going to hand over to my colleague, Joshua, because this was in my talk, not realising I was going to do this talk. And Josh is just going to talk to us a little bit about the Adelaide score.
Sure, so most of us here...
You already know, you're spoiling my story.
50% were involved with doing this. But the goal with the Adelaide score is, one, to provide a measure of a patient's likelihood of being discharged within the next day. This is validated in a general surgery population. But really, and part of the reason we were talking about before that we've called it the Adelaide score, is we wanted to symbolise a lot of the AI work that will be coming within Central Adelaide especially, and across South Australia. We think that this can have like a potential to reduce ramping because it solves or decreases a lot of the outflow issues that we're currently having in hospital. Currently, a lot of the programs that we've seen being implemented are focusing on the inflow and trying to make that more efficient. And while that's important, we are already very efficient at that. So with the Adelaide score, we hope that this will provide a predictive tool that will allow a lot of the staff to prioritise their tasks early, ahead of time, and get patients out smoothly once they've been medically cleared. Part of the initiative, we're moving on to an implementation study for this, and we really hope that that can pave the way for further implementation studies, both within our group and other groups in South Australia as well.
No, it's really exciting, and it was one of the things that I knew, because as I said, we were talking about, you know, how people get in using the technology, how we reduce their length of stay in the middle, and how we can get them out. So it'll be really interesting to see how the implementation pilot goes with that, and really exciting, another exciting piece of work going on. And we were talking earlier, so how do we get from encyclopedias and Commodore 64s into iPhones in terms of thinking about, I think, what is going to be quite a tsunami of ideas and technology, and the way that we can do our work differently. And so we've been talking about this notion called digital first, and we're calling it, originally it was called a digital factory. I didn't necessarily like the digital factory idea, but the idea is about when we're trying to solve organisational problems, we should be thinking of digital solutions first. And so it is now called digital first, because it's not that it might only deal with problems that may not have a digital solution, but we want to think about, is there a digital solution first? So digital first is our problem solving factory that we're just in the processes of scoping out. And the idea of it really is to try and look at opportunity. We talked before about looking for ways to prioritise opportunity. We can't possibly do everybody's good idea or everybody's project. But also we think it's an opportunity to bring particularly innovators, tech companies, people, good on AI, with people who have a problem, and setting up an environment where you can engage people with issues, lots of them, with people that might be able to come up with novel and creative ways. So it is about an environment in which we can bring innovation and problems together, but as I said, prioritise them and try to work out how we're best going to implement within the limited resource environment that we operate in. So a way to prioritise. The other thing that I think is important about digital first is to make visible all of the ideas and pieces of work going on. So just because you come with a really good idea, unless you have an understanding of all of the good ideas that everybody's trying to manage, I'm hoping it will help people understand the breadth of work that is going on across an organisation such as Central Adelaide. So that visualisation, we really want some key principles around thinking big, and I think we started tonight talking about some of those opportunities. How we can do things small but scale fast. Lots of people are piloting and trialling different bits and pieces. How do we do that to prove a proof of concept but move very quickly to then move on, particularly with the technology and innovation, because it will move very fast as well. If we take too long with a digital front door, for example, it'll be obsolete by the time we're up and getting it going. Prove the value and measure the success. My team's a little bit sick of me already. We're really busy doing lots of really good things, but we're not really good at measuring it. We're not really good at sharing and celebrating the success and letting people know whether it's been successful or a failure. Fail fast, it's not necessarily a bad thing, because you learn lessons from that. So we have to get better at trying to demonstrate and measure the impact that something has had for the effort and implementation. Obviously, it's about engaging with our staff, and particularly those people who either have the problem or who have the solution. It is about creating an environment that is more innovative than we probably have been in the past, and really creating the skills and culture so that we can be more innovative. And it's a bit of a vicious cycle. The more we innovate, the more people want to innovate, and so on. And again, for us, it is a little bit about having a bit of a process to support the sort of improvement model that we want to take forward. Trust me, this is the last slide. So just how do we do the design? How do we make sure that we've got the evidence, and how do we make sure that we get something in the right possible way? We have done a couple of technology interventions where we've only procured something on a small scale and then you can't ramp it up because the procurement rules are so strict. So you might get something in at $50,000, but to scale it up is $1 million, and there's a whole different piece of work that needs to be done. That please don't ever get involved in procurement. Let somebody else like me deal with that. You don't ever want to know about procurement. And then obviously, how do we best implement, and that includes the evaluation and the feedback cycle. How do we continue to innovate? How do we get people's feedback to improve? How do we set up a culture of continuous improvement and refinement to optimise the effort that people have put in to make something work? So digital first, I think, is a great opportunity for us to help us move from encyclopedias and all of those other things and really optimise the technology that we've already got. That's it from me, and I'm really happy to take any questions on that topic or any other topic related to Central Adelaide while you've got me.